Welcome to episode 20 of the ProPA podcast. I'm your host, Prof. G, and today we're wrapping up our pulmonary neoplasm series with a clinical medicine brief on carcinoid syndrome, a rare but important topic for both the PANCE prep and clinical practice. In this episode, we'll cover what is carcinoid syndrome, pulmonary carcinoid tumors, clinical presentation, diagnosis, workup, management, and treatment. And as always, we'll end with vignette-style questions to help reinforce what you've learned. Let's get started. First, let's look at the kinder patho. What is carcinoid syndrome? Well, I think the very first thing we need to establish is that a carcinoid tumor can secrete hormones that causes carcinoid syndrome. And so carcinoid syndrome and carcinoid tumor are not exactly the same thing. Carcinoid syndrome occurs due to the release of vasoactive substances like serotonin, histamine, bradykinin from neuroendocrine tumors or NETs. And these are typically when these tumors metastasize to the liver or to the lungs. Since we're talking about pulmonary topics right now, we're focusing mainly on what they do around the lungs, but we will cover the other symptoms that they have otherwise. The lungs are a common location for carcinoid tumors, which can sometimes lead to localized hormone release without liver metastases. And these hormones result in systemic symptoms including flushing, diarrhea, and wheezing. So a key clinical pathopearl is that pulmonary carcinoid tumors can cause carcinoid syndrome because the lungs drain directly into the systemic circulation, bypassing hepatic metabolism. So what are pulmonary carcinoid tumors? Pulmonary carcinoid tumors are a rare neuroendocrine tumor that can account for about 1 to 2% of all lung cancers. They are typically low-grade malignancies, but they can occasionally metastasize. There are basically two types of carcinoid tumors. There are the typical carcinoid tumors and the atypical carcinoid tumors. Now, the typical carcinoid tumors have low mitotic activity and rarely metastasize. They account for about 90% of the pulmonary carcinoid tumors. And then we have, like we said, the atypical carcinoid tumors, and these have a higher mitotic activity. They're more aggressive and they're more likely to metastasize. Some of the risk factors for developing these type of tumors, well, there is no strong correlation with smoking like some of the other lung cancers that we've seen, and it's actually more common in younger patients compared to the other pulmonary neoplasms. So, what is the classic clinical presentation of carcinoid syndrome? Well, I like to think of it as like weepy, leaky, and flushy, right? So, flushing is the hallmark symptom of carcinoid syndrome. So you get these episodic, sudden, bright red flushing, and it's also triggered by stress, alcohol, and certain foods. These patients also can get diarrhea, which is a secretory type of diarrhea, and it's due to the serotonin overproduction. These patients can also wheeze, so because they get some bronchoconstriction caused by the histamine and serotonin release. And they can also have some other symptoms related to their skin, their heart, and those are the right-sided heart failure valve lesions due to the serotonin-induced fibrosis. So right side of the heart is affected about 40% of the time, whereas the left side of the heart only about 13%. And they can also get some fatigue, abdominal pain, or signs of localized tumor growth like obstruction or hemoptysis within the lungs. They can also have, again, like we mentioned, those skin manifestations. Flushing is going to be the number one skin manifestation about 85% of the time. We can also see some telangiectasias, cyanosis, and pellagra. What are the pulmonary specific symptoms? Well, we can expect to see some cough, wheezing, hemoptysis, or recurrent pneumonia due to that airway obstruction. So how do we work up carcinoid syndrome or a carcinoid tumor? Well, we want to start with some imaging. We'll get a chest x-ray. It might show a solitary nodule or a hilar mass, but the preferred imaging modality to characterize the lesion would be a CT scan. We can also do an octreotide scan or somatostatin receptor scintigraphy, and this highlights neuroendocrine tumors. The major lab study that we want to know about for this is going to be the 24-hour urine 5-HIAA. This is very, very important. I see this tested more often than anything else. And it's going to indicate elevated levels of serotonin metabolites, and it will confirm carcinoid syndrome. Another thing that we have to consider is getting a biopsy. If we do see that mass, we want to biopsy it for a definitive diagnosis. Again, remember that the more centralized lesions, we can perform a bronchoscopy to get that biopsy. So, how do we manage and treat? Surgical resection is going to be the mainstay of treatment. So, primary treatment for localized pulmonary carcinoid tumors. And typical carcinoid tumors often respond really, really well to surgery. We can also use adjunctive medical therapy for carcinoid syndrome. So remember, we have a overproduction of these hormones, and so we want to give octreotide, a somatostatin analog, which helps inhibit some of that hormone secretion, and it can alleviate the flushing and the diarrhea symptoms. We also can treat symptomatically, so giving the patient antidiuretic. We can also treat symptomatically, giving the patient antidiarrheal medications or bronchodilators for their wheezing. For the more advanced or metastatic disease, we want to target these tumors with chemotherapy and other targeted therapies used for the atypical type of carcinoid tumors. And it has been shown to have limited effectiveness. However, these are things that can be tried. All right, some quick clinical pearls. Carcinoid syndrome is rare, often underdiagnosed, and always considered in patients with episodic flushing, diarrhea, and wheezing. Right-sided heart lesions, especially tricuspid regurgitation, are a hallmark of carcinoid syndrome due to the serotonin's effect on the heart. But not all carcinoid tumors cause carcinoid syndrome. This depends on the tumor location and the hormone release. And last but not least, octreotide is both diagnostic via somatostatin receptor imaging and therapeutic for carcinoid syndrome, which is good to know. All right, now it's time for our knowledge check. Question 1. A 45-year-old female presents with episodes of flushing, watery diarrhea, and wheezing. She has no significant smoking history. Chest CT shows a central lung mass. What is the most likely diagnosis? Is it A, adenocarcinoma of the lung, B, pulmonary carcinoid tumor, C, small cell lung cancer, or D, tuberculosis? I'll give you a few minutes to think about it. If you said B, pulmonary carcinoid tumor, you are right. It is what we're covering, so it doesn't seem too difficult. But as you can tell, the combination of flushing, diarrhea, and wheezing, those are going to be your key clinical indicators of carcinoid syndrome. And it's often caused by those pulmonary carcinoid tumors. All right, question 2. A 50-year-old male with a history of carcinoid syndrome presents with worsening diarrhea and flushing. Lab studies reveal an elevated 24-hour urine 5-HIAA. What is the best initial treatment? Is it A, surgical resection of the tumor, B, octreotide therapy, C, antidiarrheal medication alone, or D, chemotherapy? I'll give you a little bit. If you said B, octreotide therapy, you are right. So octreotide is the first-line treatment for symptomatic relief in carcinoid syndrome, especially for hormone-mediated symptoms like diarrhea and flushing. All right, I want to thank you for joining me on this episode of the ProPA podcast. We have covered everything from primary lung cancer to pulmonary nodules and today carcinoid syndrome. And this will wrap up our pulmonary neoplasm series. And if you found this episode helpful, don't forget to hit follow and turn on notifications so you never miss a new episode. And as always, this is the ProPA podcast, where future pros in medicine are made. I'll catch you in the next episode.